When you're about to intubate a pediatric patient, you might feel stressed out. The airway is smaller, the equipment is different, and you probably haven't intubated as many children as adults. With all those thoughts running through your head, the SOAP-ME acronym gets you back to the basics to help you get going when you forget where to start. SOAP-ME stands for suction, oxygen, airway adjuncts, position, meds monitors, and end-tidal CO2. You may need to remove secretions such as mucus, phlegm, saliva, or blood from the airways to clear up your line of sight to make intubation smoother. You can't put a tube in if you can't see where you're going. The most common type of suction catheter is a Yonker, which comes in a bulb tip and a straight tip. Infants have smaller oral cavities and airways, so you might want to use a straight tip so it can fit into the smaller spaces. The bulb tip is less traumatic than the flange tip due to its rounded edges. Before intubation, you must pre-oxygenate the patient. This is a way of increasing arterial oxygen concentrations right before an airway procedure in an effort to reduce the risk of hypoxemia. For all patients, you will ideally pre-oxygenate using 100% FiO2 for 3 minutes of normal tidal volume breaths, or give 8 full tidal breaths. To further prevent hypoxemia, you can do apneic oxygenation. You'll leave the nasal cannula on after giving medications that make them apneic to create a high to low oxygen gradient. This allows oxygen to still diffuse across their alveoli, even when they are not breathing themselves. Oxygen through a nasal cannula can be irritating, so you can use a lower flow rate in younger children. For example, 5 liters of O2 per minute in an infant versus 15 liters of O2 per minute in older patients. It's important to remember that you're not accomplishing ventilation here. The CO2 will still rise and the pH will still decrease, causing a respiratory acidosis. Acidosis is not a good thing in resuscitation, but at least you're buying some time by keeping the patient oxygenated while you work. Remember the formula age over 4 plus 4 that we use to determine the uncuff ET tube size in the 234 rule video? Well, another shortcut is that an ET tube size of 3.5 is typical for patients at birth, while an ET tube size of 5 is for 5-year-olds. 3.5 at birth is the magic number, because it's also the typical weight in kilograms of a full-term newborn. So, just remember 3.5 at birth and 5.0 at 5 years. If a patient is older than a newborn, but not yet 5 years old, pick a size in between. In the case when you can't get the ET tube in on your first attempt, you want to have backups on hand so that you're not scrambling to look for them after the failed attempt. This includes things like a bougie, OPA, NPA, PEEP valve, and an extra ET tube 1/2 size smaller. When it comes to intubating children, you can either pick a Miller blade or a Mac blade. A Miller blade is narrower and easier to fit in tight spaces, while a Mac blade is wider and can provide better tongue control. Both options will come in the same sizes. We use a size 0 for infants and a size 2 for 2-year-olds. An easy way to remember this is 0 at birth and 2 at 2 years. For teenagers or patients who are close to adult size, use a size 3 blade. A lot of failed intubation attempts are a result of bad positioning, so before you intubate an infant, make sure their positioning is correct. You always want the opening of the patient's ear to be lined up with their sternal notch. This can be done by either adjusting the bed to raise their head to the appropriate angle, adding a towel or blanket to do the same thing, or a combination of both. M stands for medications. You'll want to have an induction agent and a paralytic ready. If you forget which medications are typically used and their dosage, no worries, just fire up Pocket PEM. But the big takeaway is that you'll always want to have your post-intubation medications ready to go at bedside, which usually include an analgesic and a sedation drip. Drips can take some time to prepare, so you need to have some bolus doses ready so that the patient doesn't wake up or experience pain. End-tidal CO2 helps you because a regular waveform is a very accurate way to confirm that the tube is in the trachea. It can also help you adjust ventilation settings prior to getting blood gas results, which takes time. The end-tidal monitor should already be attached to the bag so that you are not scrambling for it after you have already started bagging the patient. After you intubate, your respiratory therapist will ask you for ventilator settings. Don't be scared though. Simplify your life and use pressure control instead of volume control. That way, you won't have to calculate a tidal volume up front. This makes life a whole lot easier and is typically preferred in children. So just use a positive inspiratory pressure of 20 over a positive end expiratory pressure of 5 in all children, and then adjust those settings depending on the volumes you get. Shoot for 6 to 8 milliliters of tidal volume per kilogram, and don't forget to order your post-intubation chest x-ray. Start at FiO2 of 100% and adjust down as tolerated. Set the respiratory rate according to age, which is usually 30 for infants, 20 for kids, and 12 for teens.